Our next speaker is Professor Craig Meyers, who is a distinguished professor of microbiology and immunology at Penn State University's College of Medicine. He's achieved national and international renown for his work on human papilloviruses, or HPVs, with over 100 published studies on HPV replication and oncogenesis, viral structure, infectivity pathways, immune protection, and resistance to disinfectants.
Thank you for that introduction. I just want to tell you I am a basic scientist. I'm coming in, I'm a virologist. I work with cancer viruses. If somebody had told me 10 years ago I'd be standing in front of a group of sonographers talking about HPV, I would have not known what they were talking about. But so we'll get started here. Okay, so just some conflict of interest statements, just to let you know, part of the studies that I'm presenting were funded by Nanosonics Limited, and I'm presently a consultant for Nanosonics, and that the views expressed in these presentations are those of mine and do not necessarily reflect the position of SDMS or Penn State University. I have done work with other disinfectant companies, and I'm still continuing to do that, so I am testing other things too. So, learning objectives. Describe the evidence for the risk of HPV transmission from ultrasound probes, and understand the limitations in the efficacy of commonly used ultrasound probes, disinfectants against HPV, and describe the regulatory criteria that must be met by an ultrasound probe high-level disinfectant to claim efficacy against HPV. So this is the little chart. You know, we often use this in the field to tell you how important HPV is. In fact, over 5% of all cancers in the world are due to HPV. That's 1 in 20 cancers in the world are due to infection by HPV. And you can see here that nearly all cervical cancer cases are HPV caused. You have vaginal cancer, anal cancer, penile cancer, vulvar cancer, and oropharyngeal cancer. And I want to just comment that the anal and oropharyngeal cancers are the only 2 cancers in the United States of any note that are still increasing in the population. Anal cancers are twice as likely to be in women as they are in men. This has just been recently studied. And oropharyngeal cancers, there's over 600,000 oropharyngeal cancers due to HPV in the world this year. And if it hasn't already happened very soon in the United States, there will be more people with oropharyngeal HPV cancer than there will be with cervical cancer. So it is a very important cancer that's on the rise here. A lot of people are infected with different HPVs. We got skin warts and all these are all HPVs, but less than 5% are infected with the high-risk types, HPV 16 and 18. And these are the 2 types that cause most of the cancer. HPV 16 in the cervix is the cause of over 50% of all cervical cancer, where 18 adds about another 20% or so onto that. So, you know, we always used to lecture, and it was taught to medical students that HPV is a sexually transmitted disease, and that's true. It is the most common sexually transmitted disease in the United States. It's often not even included in the tables. For what reason, I don't know, but when they talk about sexually transmitted disease, sometimes HPV is not mentioned. But it's the most common one in the United States, but it's now become more realize, and it's something we talk about, is that HPV can be transmitted non-sexually. They looked at children, and even though a couple of them unfortunately were due to sexual abuse, most of the cases were considered non-sexual transmission, most likely to prenatal mode. Also, there is about 50% of non-sexually active women in the United States that are HPV positive. And this is a big problem to prove, and there are a lot of litigations going on in the United States of women trying to sue their OBGYN or their healthcare provider, but none of these cases have been successful so far. And as was just mentioned, HPV is found on the fingers. If you take a group of people that have anal genital infections at any one time, 20% of them will have that HPV on their fingertips. And so it's another reason I tell people not to shake hands. HPV is highly resistant and contaminates medical devices. It resists desiccation. It's highly resistant to disinfectants, and I'll show you some data in a minute. And HPV remains infectious in a typical dry room environment for many, many days. HPV on medical devices, we know that over 43% of colposcopes were shown to be contaminated with HPV. 3 to 7% of the ultrasound probes are contaminated with HPV. And you know, even the glove box in the OBGYN office has HPV on it. And so it's everywhere. HPV transmission risk from ultrasound probes is something that we need to be concerned about. We know that ultrasound probes come in contact with the common HPV cancer sites. The transvaginal, transrectal, and transesophageal probes all can come in contact with sites. Now, we're showing pictures here of the cancers, but you have to remember HPV is one of those viruses that you can have for literally decades before you show any symptoms. So a person can be replicating the virus and spewing it out into the environment. So just because there's no clinical signs of HPV infection does not mean the person is not infected. In fact, we know at college-age women, at about 80% of them are probably infected with HPV at any one time. The sonography environment is also contaminated with HPV, and I'm showing you a little, this is from a paper where they went in and looked at gynecological equipment, and you can see here again the colposcopes have it, the gel has it, the lamps have it, the glove box. Something we don't talk about here is the dental office. That's a whole nother story. Next time, every time I go into my dentist, I look around at what's not really covered or being touched. Ultrasound equipment, the environment can be contaminated with HPV through the hands or the gloves. Contact of devices with mucosal surface creates a high potential for transmission risk. Proper storage of ultrasound probes important. There should be no airflow, clean location, probe storage covers, and to prevent recontamination from the environment. So there's many examples from endoscopy suggests that devices reprocessing lapses occur. We heard a little bit about that, but this is a very, you can have the best protocols in the world, but if people don't follow them, they're no good. And so less data on reprocessing lapses in ultrasound does not mean lapses do not occur, and proper reprocessing of ultrasound probes is important to mitigate transmission of pathogens such as HPV. Now, we heard a little bit about covers on these probes. These probe covers break, they have holes in them. Condoms also have holes, and there's been studies that show even though visual observation of the cover shows that there's no breaks or defects in it, there are still contamination of HPV on the probe. So you need to choose the right disinfection method for ultrasound probes. And so, we look back at the Spalding criteria, which is the globally adopted system. Disinfection of medical devices or surfaces depend on its intended use. We just heard a lot about that. Each disinfection level is defined by a specific pathogen activity spectrum. And so you can see here are the little tables. So we have the critical, the semi-critical, and the non-critical classifications. Again, sterile tissue or blood, mucous membranes or non-intact skin, or healthy intact skin. The level of disinfection for critical is sterilization. For semi-critical is a high-level disinfection, and for non-critical, a low-level disinfection. So the definitions for this, sterilization means all microbial life is killed. All life is killed in that. So, and for high-level disinfection, the definition by the Spalding criteria is that it destroys all microorganisms except spores under normal use and spores at extended contact times. So according to these definitions, if you ask the question, should it kill HPV, then the critical and the semi-critical classifications, if you're using those, they should kill HPV according to the definition, where low-level disinfection should not. The definition doesn't require that that would be killed. So, common disinfectants haven't been tested against HPV until now. One, high titers of native HPV, the actual virus. The production has not been previously achieved. In 1992, I published the first paper where we could grow HPV in the laboratory, and now we have stocks of high enough quantity that we can do all kinds of different testing with it. Common hospital disinfectants have not been tested against HPV until a couple years ago. My collaborator who works on disinfections with select agents came to me and just said, nobody can say that their disinfectant can kill HPV because they've never done the test. And so he said, why don't we do it? So we did it, and that's my big head first dive into this area of disinfection. And so we tested this against many common disinfectants, some that are considered sterilants, some that are in the high-level disinfectant categories, and some in the low-level disinfectant categories. And we expected these things to work, to kill HPV. We didn't go into this thinking the results that we got. So this is the basic protocol we use. We grow this organic typic culture system. We're actually growing full-thickness human epithelium. And in the lab, we can grow foreskin, cervix, vaginal, anal, tonsil, gingiva, really pretty much anything we can get our hands on and have a reason for, we can grow. We have these cells, they're infected, they're productively infected with HPV. We grow these for about 20 days. We peel the skin off of this. We harvest the virus by grinding up the tissue in a Downs homogenizer. The supernatant we get off of that has our active infectious HPV in it. We have developed methods to titer it and to measure its infectivity. So then we just collect it. We know the titer. We know it's infectious. And then we can use that to test disinfectants against HPV. And we did our first study in 2014 using a suspension test. So basically, we just took HPV-16 and we dropped the disinfectant on it. So it was a liquid test. We waited 45 minutes. This exceeds manufacturer recommended contact times. We then had to put something in there to neutralize the disinfectant. We collected the remaining virus and did our infectivity assay. So this will tell us whether the disinfectant will deactivate or kill HPV. So again, these are our disinfectants you can see over on the left. Glutaraldehyde, OPA are at the top. These are what are used for semi-critical medical devices. They are said to be suitable for probes. They are high level. They're defined as high level disinfectants. And remember, we said if they're a high level disinfectant, that means they should be able to kill HPV. And then we tested these other things like ethanol and isopropanol, mainly because this is what people are squirting on their hands all the time, thinking that it's going to get rid of everything. Don't stop, because it does kill flu. It does kill these other viruses. Keep cleaning your hands. Phenol, this is what we used in the lab actually to kill HPV before we knew this data. We've now completely switched over to other things. PAA silver, we had 2 concentrations of that, and then hyperchlorite, which is bleach, we all know, and everything in my lab now gets bleached after we're done, and then we wipe down with ethanol so things don't corrode. But we've completely changed our protocols in the lab. So here's our data, and what we found was all the hospital disinfectants we tested did not work. So you got your 2 concentrations of ethanol, you got your isopropanol. The top of this graph is a log reduction as you go up. So that's a log reduction in HPV infectivity, and below the graph is an increase. And if anything, some of these things we believe it's just cleaning the virus and it infects even better. So if you can look here, 2.4% GTA, 3.4% GTA, 0.5% basically OPA, did absolutely nothing against HPV. The FDA mandates a 4-log reduction in viral titers. You can see that dotted red line. None of these things did anything. This 1.2% PAA silver is not FDA approved. If I remember right, it was made to kill anthrax spores, so you can't get it to use it. We have connections, so we were able to test some of it. The guy, my collaborator, actually tested it against anthrax spores, so we got it. No anthrax spores, but we got the disinfectant. And then, in this case, about 0.5% hyperchlorite. And this, when we got this data, this is when we switched. And I will tell you that when we did this study, my collaborator is 2,000 miles away from me. He did it with different personnel, different stocks of virus, different stocks of disinfectant, different stocks of cells, everything. And then we repeated it all in our lab. So it was done in 2 different places with completely different sets of everything. We then said, well, what about extended contact time? So we took the GTA and the OPA, which are, according to the manufacturer, should be 45 minutes and 12 minutes respectively. Did it kill in 45 minutes? No, I just showed you that data. It didn't do anything. So the GTA, we went to 24 and 48 hours, and OPA, we went to 24 hours. It had no effect on HPV's activity. It was still highly infectious with no drop in titers. So these challenges escalate the risk of HPV transmission with ultrasound probes. HPV is found on probes and probe sheaths after use. HPV remains on the probe after cleaning. High-level disinfectants, GTA and OPA, are HPV ineffective. They do nothing against HPV. HPV remains infectious for several days. The probe is reused. HPV transmission occurs with skin and mucous membrane contact. In fact, one of these studies that was just looking at the presence of HPV after proper protocols were done, from patient 1 to patient 6, the same HPV that was there after patient 1 was still there after patient 6. And so it is very hardy. We, in the field, basic scientists, we don't believe in anything that's intact. There's no such thing to us as intact skin because there's always microabrasions too. So there's no such thing as an intact mucous membrane to us, and there's ways we can show that. So is there a solution? We put all this out, and the CDC contacted me, and several other groups contacted me, and they said, well, what do we do? And I said, I don't know. We got to do some more testing and try other things. So the CDC's answer was just to be quiet, and that was the answer for most people who read this. It is interesting that it wasn't the doctors who contacted me. It was the nurses, the sonographers. They were reading these articles. The doctors weren't. And I teach doctors, so I know why, but that's another story for another day. Of course, they know everything. So this new system, this Trophon, they contacted me and said, can you test our stuff? And they use ultrafine hydrogen peroxide mist. And you just saw all this, so I won't repeat it. But these are the characteristics of this system. And they asked me to do a carrier test, which is probably a more relevant, real-life type of test. And again, I'm learning all this as I go because I just worry about the structure of the virus and different things like that most of the day. And so they gave us these carriers, and we dried the HPV on it. We were able to recover over 90% of the HPV after drying it. We can dry it, let it sit for a couple days, and most of the HPV we pull off is still active. This is a test required by the FDA, and so we moved on and did these assays. We tested both HPV 16 and 18 in this case. In our lab, we grow multiple types of HPV. We spread the virus on these hard carriers. We let it dry, and then we stuck them in the Trophon device. We just hung them in the device and ran the 7-minute cycle according to their instructions. Or we soaked them in bleach, or we used OPA as a control. And it's kind of odd here when you're thinking about it. OPA was our negative control. Bleach was our positive control because we knew OPA probably wouldn't do anything. So here's our data. You can see on the left HPV 16, on the right HPV 18. There's our dotted line for the 4 log reduction in titer. The asterisks mean we could not detect any infectious HPV using PCR after the treatment. You can see that OPA still does not work. Hyperchloride still does the 4 log decrease, but you can see how effective 35% hydrogen peroxide in the Trophon device was at deactivating the virus. We actually also used a lower concentration. It was still above the 4 log, and then still with 16 able to kill all the virus, but not quite as strong. So, but the device uses 35%. So what's the global response to HPV results? I can tell you what's going on in US and France. I was in France this year for their big infection control meeting, and it was very interesting listening to them. In the US, GTA and OPA, as you know, are accepted as high-level disinfectants for ultrasound probes. However, OPA and GTA are completely ineffective against killing HPV. FDA and CDC are aware of the situation, but they've not made any recommendations. I do know that the CDC funding is being sought. They're going to repeat what I did with a colleague of mine at the University of North Carolina. She told me she's waiting for the check to come in, and then they're going to go ahead and do this. In France, like I said, in June, I was at their meeting, what they call the SF2H conference. Their guidelines advise that if on inspection of the sheath and the probe, if there's no tears or soiling, then low-level disinfectant is acceptable. They were happy to find out, because I guess they always get picked on by the US, like we do high level, you do low level, and they found out that HPV doesn't care if it's high level or low level, if you're using the wrong stuff. I am in contact still with them. They're planning to set up a reference lab in the country. This is their goals right now, but they're going through government budget right now, so who knows what happens after that. But they want to do a reference lab to test all disinfectants that are going to be used in France. One thing I'll just add in right here is, a lot of contamination, this whole brachioscope thing that happened in Southern California like a year or so ago, those type of contaminations, the patient gets sick very quickly after they get infected. With HPV, it could be decades before you know somebody's infected. So it would be nearly impossible to trace back an HPV infection to a hospital, to a practice. And so what we're talking about is potential risk. And so that's something to think about here. And the vaccine is out there, and I want to just say this, that less than a third of those who qualify for the vaccine in the United States are getting it, and so the future doesn't look bright for actually getting rid of HPV through vaccination in the US. In France and Germany, less than 20% of the people are being vaccinated, and I just heard that this last year, Japan has wiped out the vaccine program altogether, so they're not even doing it anymore, and countries are considering, why should we do this? And so the internet can be a great place for information, but it can be a great place for misinformation, and most of these problems are due to the internet. So what can a sonography professional like you do to protect your patient? So practical HPV risk mitigation. These are just practical suggestions. Alcohol and hand rubs and environmental disinfectants kill bacteria and some viruses, but do not kill HPV. But hand washing with soap, we heard about the gels and the debris. You can get rid of all that, and that physical washing, everybody asks me this question, so I'll tell you before you ask me, have we tested soaps? We have not tested soaps. Someday we need to test hand soaps to see what they do. Gloves are best for all pathogens as long as they're changed between patient examinations and before handling process probed, and also before you touch the glove box again. People think the glove box for some reason is clean. It's not, because sometimes people think about putting on gloves after they've touched something. Take care not to contaminate your hands when removing your gloves. Reducing transmission risk from surface and probes. Hyperchlorite kills HPV, so you might want to consider intermittent surface cleaning with hyperchlorite, or physical cleaning can help remove the microorganisms. Automated H2O2 devices kill HPV, and these are designed for ultrasound probes. This is the only thing I know so far, besides bleach and this high concentration paracetic acid, which you can't get, that will kill HPV. And this is very important for intercavity probes because they contact the common HPV infection sites. So reducing transmission risk via probe storage, we heard a little bit of this already. Consider using storage covers. store reprocessed probes. Because remember, if 20% of people have it on their fingertips that are infected, somebody comes and grabs the probe, they've just put it back onto the probe. Store the reprocessed probe in such a way to prevent recontamination from the environment. Handle reprocessed probes carefully to avoid cross-contamination and handle with fresh, clean gloves only. Make sure the probe is thoroughly dry before reprocessing, and store away from airflow, heat, humidity, and moisture. Okay, so how to ensure disinfectant is effective against HPV? Carefully review the justification for all efficacy claims. I've walked around when I come to these meetings, APIC, this meeting, and the group in France, I see claims that it kills HPV, and when they've never tested it. In Germany, they will tell you it kills HPV because it kills SV40, a non-human virus. So, you got to really look at these claims. In Canada, they have claims that all these disinfectants work on their disinfectant sheets, but there's no data to back it up. The only test acceptable to establish efficacy against HPV in the US is the test on native HPV virus. There are surrogate recombinant particles out there. We tested those. They are not the same. To establish efficacy, the FDA requires the use of large amounts of virus in standardized tests to represent the worst case scenario. So, summary, there is a risk for HPV transmission from ultrasound probes. At present, we are the only lab in the world that can test efficacy against native HPV because we're the ones who grow it, although I am teaching colleagues, but they're all basic scientists too. So we have found GTA and OPA don't kill native HPV. We have found that the automated sonicated hydrogen peroxide device is the only thing I know of that's effective against killing HPV, and steps to mitigate HPV risk transmission via ultrasound probes, adhere to reprocessing guidelines, apply the Spalding criteria, use HPV effective disinfectants for ultrasound probes in the environment where possible, carefully review the efficacy claims for disinfectant products. And I sit behind the desk and write the grants, and these people, especially the two in red, are the ones that actually did the hands-on work in my lab. And so we'll stop and I guess take any questions.